So we'll be talking today about volume responsiveness in the ICU, and we were mentioning a little bit earlier. We want to try and drift away from ideas like wet and dry when we talk about fluids in the patients, and when we're trying to decide whether to give volume to a patient. The question we really want to know is something about this patient's condition going to get better if I give them volume. Okay? So, as an example, congestive heart failure guy, his blood pressure may be low, he doesn't need more volume, right? Guy who's really, really dry, because there's bleeding to death, he needs volume. All right, so we'll talk about this, and that's really what we're trying to figure out. So, when you're trying to think about whether somebody is going to benefit from volume, you have to go to a couple fundamental concepts. One is the idea of oxygen delivery. Okay, your heart and your lungs are pumping blood out. This blood is carrying oxygen, and the oxygen is going to your tissues. So the question you need to figure out is that oxygen delivery enough? And if I've decided it's not, if I don't think the perfusion is good, the question is giving more volume going to help? So if you want to think about how much oxygen is going out, it's the same as if I'm moving patients or people from New York to Miami on a train. The number of people that I can move on the train is really only a function of three features. One, the locomotive, so cardiac output. Two, the number of boxcars you have, so hemoglobin. And if each boxcar has 100 seats on it, how many of those 100 seats are filled with a person? Now this PaO2 over here, notice it's multiplied by 0.0031. If we're in rounds, I don't feel any better about a PaO2 of 61 than 59. Okay? So if you are trying to decide whether you can turn that FiO2 down on the vent, you don't need a blood gas to figure that out. Now the blood gas is helpful to figure out why your sats are low, but this PaO2 here, it's a very, very small contributor to oxygen delivery. If this was the train to Hogwarts, okay, this is the dude selling the chocolate frogs, okay? He's not a player, okay? Harry, Hermione, all those dudes, they're here. They're the sats in the hemoglobin, all right? So, cardiac output, hemoglobin, sats. Now, another equation that's important to know. When you're thinking about low blood pressure, so there's, I don't know if you remember back from your physics days, so Ohm's law. So V equals IR. Voltage equals current times resistance. And I don't know how physics went for you, but let me tell you how physics went for me. My first semester of physics, I crushed it. There were balls rolling down ramps and kinetic energy and potential energy. Second semester physics, they started talking to me about electrons going one direction and charge going the other. I was out. But what I do remember from second semester is Ohm's law. V equals IR. So pressure drop across the system is equal to current times resistance. In the human body, from a system standpoint, this translates to mean arterial pressure minus CVP. So the blood pressure coming out of your heart relative to the blood pressure going back into your heart. That pressure drop across your system is a function of two things. Current, so cardiac output, your locomotive, and resistance, so systemic vascular resistance, which basically means that blood pressure is largely a function of cardiac output times resistance, which means if my blood pressure is low, then I can only have three possible states. Either one, my cardiac output is low, two, my SVR is low, or three, both are low. And you can figure that out on physical exam pretty quickly, right? If your tone is high, your vascular tone is high, and I grab your hand, is it going to be cold or warm? Cold. If your vasodilated, if your tone is low, it's going to be warm. So one of the first things I do, if you call me into the room and say, hey, his blood pressure just dropped really quickly, I'm going to walk in, I'm going to grab his hand. Because I want to know, is he clamped down? I'm going to grab his hand, I'm going to grab his feet. I'm trying to feel, are they warmer than I would expect, or are they cold? If they're cold, then he's clamped down, and the SVR probably isn't the problem. It's all a cardiac output problem. But if the legs and the arms are warm, then SVR is a problem, and it's one of these two. But the point being, these two equations are going to be a big deal. So, let's say you decided your perfusion's not good, okay? Or your oxygen delivery is not good. So you said, okay, my oxygen delivery is not good. And I know this, talk for another day, but I know this because my mixed venous sats are low. My lactate is coming up. I have evidence that the person is not getting enough oxygen. So then I go back and I say, well, are the person's oxygen saturations good? Oh yeah, his sats are 98%. Okay. How about his hemoglobin? Is his hemoglobin okay? Yeah, his hemoglobin's 12. Okay, that's probably not a problem. So now you've isolated it to a problem of cardiac output, right? So then I say, well, what's cardiac output? That's heart rate times stroke volume. How do I know at the bedside what the stroke volume is, whether it's good or bad? What's a simple thing I can do?
How wide the pulse pressure is?
Absolutely. Absolutely. Pulse pressure. Now we're going to spend a little bit of time talking about pulse pressure today. So pulse pressure, he speaks the gospel, is the difference between systolic blood pressure and diastolic blood pressure. The bigger the difference, the bigger the pulse pressure, the bigger the stroke volume. The narrower the difference, the narrower the pulse pressure, the narrower the stroke volume. So I can stand in the room, look up at the monitor, know whether my stroke volume is normal, high, or low. I can have my hand on the patient at the same time and know whether they're clamped down or not. I can learn a whole lot about the patient without doing anything. Here's the secret. Do my job. It's so easy. Because all you gotta do is just a handful of things, okay? It's nice, okay? It's awesome. So you can learn a lot. So let's say you've determined in your patient that cardiac output is low. You know the oxygen delivery is low because the lactate's coming up. These are good, so the cardiac output is low. The person's tachycardic, heart rate's 130, 140, sinus doing its thing. The pulse pressure's narrow, so I have a problem with my stroke volume. Stroke volume is a function of three things, and it's very, very intuitive. It takes some practice thinking about it, but it's actually very, very intuitive and makes good sense. Hope I spelled that right. All right, stroke volume, right? If I have a bunch of blood that has to get out of a ventricle, then the amount of blood that comes out is determined only by three things. Afterload. How hard is it to get out? If the door is closed, I can't get out. If I have aortic stenosis, I'm stuck in the room. Okay? But if the valve opens well, I go right out. No problem, right? Same thing with the heart. The nice thing about afterload problems is that unless your blood pressure is really high, you probably didn't just develop aortic stenosis right away. It was probably a problem you already knew about. But sometimes you'll make that diagnosis for the first time, so afterload is a problem. How hard does the heart have to work to push blood out? The harder it has to work out, the harder it has to work, the less blood it's going to be able to push out. Okay? Contractility. How well does it squeeze? Let's say you've got plenty of blood in that cavity, but it doesn't squeeze well. Okay? And then last but not least, the preload. If you don't have much blood in the cavity, it doesn't matter how well you squeeze, you're not going to get much out. Okay? So let's say in your patient, your blood pressure's on the soft side, they're vasodilated because their hand's warm, okay? Blood pressure's low, your lactate's coming up, they're septic, they got a fever. Cardiac output, you think is low because this is normal, sats are normal, heart rate's high, pulse pressure is low, so the stroke volume is low. You know he doesn't have aortic stenosis, and because his blood pressure is low, if he didn't have aortic stenosis, it's not an afterload problem. So either this isn't squeezing well or you're dry. So the question is, and this is where we're going with this whole talk, is how do I know whether giving more volume, i.e. increasing the preload, will help the patient? That's what I want to know. Okay? What's the simplest thing I can do to figure that out?
Try it.
Yeah, I can give volume and see what happens. Right? That's not crazy talk at all. In fact, statistically, that's the most likely thing we're going to do. If you think the person's septic, Surviving Sepsis Campaign guidelines say what? Give a bunch of volume, see what happens. What do they say? Oh, I don't know. They give, 30 cc's per kick. as an initial bolus. So 100 kilogram person, 3 liters, bam. That's where that, hey, give 2 liters of LR, give 3 liters of LR comes from. Right? We're guessing. And you know what? If all of a sudden I gave it and life got better, guess what? He needed more volume. Check. But let's say the person has a big pulmonary embolism, or they're in heart failure. Fluid's already backed up. They've got JVD up to here. If I give more volume, not only am I not going to help them, I might hurt them. So I have to have some way of assessing whether it's likely this person is going to get a benefit from it. So one thing that's well described and probably is well validated in the literature as almost anything else is something called passive leg raise. Okay, if I lay you down on your back, okay, whole bunch of blood pools in your venous circulation. It just pools there, it just sits there. The capacitance side of your circulation. The majority of your blood at any given time is sitting in your veins, the venous side. The way your body recruits volume really quickly is it cranks up your sympathetic system and makes your veins tight. And it squeezes more blood into your heart. It's like auto-transfusing yourself. So if you get in problems with trauma, you're in a car accident, it's one of the first things that will happen. Your veins will go just like that. Blood comes up. So I can do this to you though. If you're lying in the bed and you're septic, all I got to do is lift your legs. If I lift your legs and hold them up, you auto-transfuse yourself. Okay? You give yourself 1 liter to 2 liters. And I either see a response or I didn't. Now, 2 possibilities. 1, I see a response. Actually, 3 possibilities. 1, you had too much volume no matter what. It didn't help you. 2, I saw a response. Or 3, it wasn't enough. Maybe you need more than 2 liters to... So that's the problem. The other thing is you're going to have to monitor the cardiac output while you're doing it so you see. Sometimes the blood pressure will come up, but usually you're having to monitor the cardiac output. So other ways I can do it. So let's say this guy is intubated. How can I figure out what his volume status is? What do we see a lot of people ask for? You want to say it? Say it.
Stroke volume variance.
Okay. Yeah, so we'll get to that. I like it. I like it. You can't jump to the conclusion that fast. You can't. Even if you're right, you can't. Okay? This is on film. You have to give the wrong answer a couple times first, okay? So we guide you to the right answer, all right? So you're exactly right. So stroke volume variation and pulse pressure variation are where we're going to go with this, absolutely. What other things have you seen?
Did you look at the SpO2 waveform if you don't have an A line to it?
Yeah, so people have tried that, yeah. And there is actually good sense to it, and it goes a lot. It depends on the technology you're using. There's a company called Massimo, no financial relationship. There's a company called Massimo that actually does that. And it actually looks at the pulse pressure waveform and gets a sense. And it's actually the exact same concept as pulse pressure variation, stroke volume variation. So we'll get back to that. It's just a different technology to measure the same thing. So perfect. I like that. I like that. How about central venous pressure? So we see it less in a medical ICU now than we used to. Okay, when I was a resident back in 1900s, actually quite literally in the 1900s, when I was a resident in the late 90s, CVP was everything. Okay, put a CVP in. Oh, CVP is 3. Give him volume. Oh, CVP is 20. Oh, he doesn't need volume. Right? So a couple problems with this. They did a study actually in the early 2000s, I think it was. It may have been late 90s. And they took septic patients and they put central venous pressure tracings in them. If your CVP was less than 4, what do you think the percent chance was that you would benefit from volume if you were septic?
100%. If you were septic, 100%. That's close to way up there.
50%. If your CVP was 3 and you were septic, you had a 50% chance. 50% chance of responding to fluid. Why is that? It's very weird. Here's another riddle. Okay? Here's a riddle. You see this in trauma world. So, trauma patient comes in. Ready for this? Bleeding. You're watching them bleed in front of you. There is no doubt in your mind this guy's dry. You're watching it. Someone puts in a CVP tracing, right? Here's what we get. The guy's on a vent, okay? His heart rate is 130. Blood pressure is 60/40. And his CVP is 14. Okay? They clamp the bleeding artery, give him a whole bunch of blood, resuscitate the heck out of him. And his lactate, by the way, here was 12. And his urine output, zilch. Okay? Give him a bunch of FFP. Give him a bunch of blood. Give him platelets. He starts to pee. Blood pressure comes up. Heart rate comes down. Lactate starts to clear. It's 2 now. CVP? It's 4. No doubt he was dry. No doubt he responded to volume. He has a narrow pulse pressure. He has a low oxygen delivery. He has inadequate oxygen delivery. He started out with a hemoglobin of 15 because he was young and healthy. If I walk up to you and I take 80% of your blood out right now, well, you'd die. If I took 40% of your blood out right now and I measured your hemoglobin right after I took it out, it's the same. Because it's going to take 12 or 24 hours for you to re-recruit volume, and then your hemoglobin starts to drop. So if I take blood, if you started out with a hemoglobin of 15, take 40% of your blood volume, draw your blood right away, it's still 15. Still 15. 6 hours from now it'll be lower. Right now it's still 15. This kid came in with a hemoglobin that was good, relatively good at the very beginning. Okay? The SATs were good. The world's greatest pulmonologist was taking care of this guy. Not me, but I know him. You know this is not the problem. This is not the problem yet. It will be. The heart rate was appropriate. Pulse pressure was narrow, so there's a low stroke volume. The kid does not have aortic stenosis, and the blood pressure is clearly not blocking things coming out of the left ventricle. He could have a contractility problem, but he's probably dry. How do you know? Because he's bleeding to death in front of you. Yet his CVP was 14. You gave him blood. You stopped the bleeding. You gave him blood product back. You did all the right things. You resuscitated him so much that he has a smiley face instead of urine output. A smiley face. You don't even care what the hourly rate is because it's smiling. His blood pressure is better. His heart rate is better. He's clearing his lactate. His oxygen delivery is definitely better, which means his cardiac output had to have come up. By definition, he had a positive response to fluid. Why did the CVP go down? If CVP is such a great marker for who needs volume, why did it go down? It went down because think of how a CVP is measured. Some people say, well, the CVP was inaccurate. Oh, no. It was accurate. It just wasn't telling you what you think it was telling you. Think about how they measure CVP. You're a triple lumen, triple lumen catheter, you're sitting in the middle of the SVC. The right atrium's in front of you, you're looking down. Right atrium's in front of you. Triple lumen's behind me, I'm the tip of the triple lumen. I'm pointed down in the SVC, okay? Was he dry here? Yes. So every time the vent pushed a breath into the patient, the SVC collapsed. And every time the vent let pressure out of the chest, the SVC expanded. Collapsed, expanded, collapsed, expanded. This number was equal to the mean airway pressure in the chest. But that's not the same thing as saying you're intravascularly plump. Once he got a bunch of volume, the number's lower, but it turns out he's plump now. Now, when I'm sitting in the SVC, the air comes in, the SVC kind of does this. It doesn't collapse all the way anymore because I've got volume, right? So this is going to be an important thing. So, internal medicine folks don't tend to like CVPs very much, at least if we've trained in the last 10 years or so. Older ones still like to rely on it. Is a CVP bad? It's not. It's not. It's just the absolute number's not that helpful. What does this CVP tracing look like? It goes in time with respiration. What does this CVP tracing look like? the tracing can actually be pretty helpful. More than the number. More than the number. Because if you see a lot of variation in CVP tracing, it tells you this guy may be dry. Regardless of what that number is, the tracing could actually be helpful. So I don't want to leave the idea with you that CVP is completely useless, but following the number on the CVP blindly is pretty much useless. Okay? But the waveform is helpful. Now, folks who you're following with like congestive heart failure, things like that, different role. That's a different patient. Okay? And that context may be a little bit more helpful because you can correlate that with specific cardiac outputs and cardiac indices and things like that. So I want you to keep this in mind. So let's talk about what Kubicki wanted to bring up a little earlier. And I like it. I like how you're thinking about this, right? Because, like we were just talking about, if the SVC doesn't have enough volume in it, it's going to collapse down. Every time a breath comes into the chest, it's going to open up every time the breath goes out, if you're on a vent. Okay? If you're not on a vent, it's exactly the opposite. You suck in, it opens up, you push out, it closes down. Either way, there's variability. Okay? There's variability. So, let's say you have a dry person. Okay? Every time the breath goes into the chest, it collapses down the superior vena cava, it collapses down the IVC, so you get less blood going to the right atrium, and then less blood going to the right ventricle, less blood goes out to the pulmonary arteries, less blood comes back to the left atrium, less blood goes to the LV, and therefore when the LV squeezes, it has a low pulse pressure, right? It has a low stroke volume because it has low preload, right? Now, the vent lets the breath go out. More blood comes into the SVC, more blood comes from the IVC, more blood goes to the RA, more blood goes to the RV, more blood goes out to the pulmonary arteries, more blood comes back to the LA, more blood goes to the left ventricle, a bigger preload in the left ventricle, therefore a bigger stroke volume. Okay? Now, let's take the person who's plump all the time, right? They're in CHF, whatever. Breath goes in. SVC doesn't change. IVC doesn't change. Breath goes out. SVC doesn't change. IVC doesn't change. So regardless of where you are in the respiratory cycle, the blood coming back to the right atrium, right ventricle, left atrium, left ventricle is the same. So the left ventricle preload does not change with respiration in that setting. It stays the same. Okay? So think about this. This is just saying the same thing, but think about this. Okay? So this is stroke volume. If I can spell right. And this is preload. And by the way, when we say preload, all that is volume. If somebody says preload to you, that is the volume in the cavity that's about to be squeezed out. Okay? So the volume that's in the left ventricle, you can talk about it in the right ventricle too. The volume that is in the left ventricle immediately before it squeezes. The end diastolic volume. Okay? So the left ventricular end diastolic volume. That's what we're talking about, preload. Okay? You get a graph. I love graphs. So you get a graph that looks like this. Okay? So, if I'm really, really dry down here, right? There's that phrase again that I told you not to use. I'm using it. It's horrible. So, if I'm really, really dry, then I'm going to bounce back and forth in here. And if I'm not so dry, I'm going to bounce back and forth here. What's this mean? If I push enough pressure into the chest, okay, I'm going to decrease the volume coming to the right part to some extent, okay? So let's say I decrease it by this much. If I decrease it by this much as the breath gets pushed in, then when the breath exhales, it goes back out. Okay? So you cycle here and here, just like this, which means you're cycling between this point and this point. Okay? Now this person, he's tanked up. He's tanked up. So if you squeeze down this way and move here, you're going from here to here. Back, forth, back and forth. The stroke volume doesn't change as the breath goes in and out of the person. Here, the stroke volume changes as the breath goes in and out of the person. This person is on a place on the curve where if you give him more preload, his stroke volume will go up. This person is on a place in the curve where if I give him more volume, he's not going to get a better stroke volume. He's not going to get a better cardiac output. Okay? So, this brings us back to the idea of stroke volume variation, or SVV, which is the same as pulse pressure variation. They are the exact same concept. Okay? Because we said earlier that the pulse pressure, the difference between the systolic and diastolic, correlates directly with the stroke volume. That's not 100% true, but it's pretty close. The vast majority of patients, it's pretty close. So this is kind of an interesting thing. And so when they've looked at big studies, lots and lots of studies looking at this, because it's an easy thing to do studies on. It's easy to do it on animals, easy to do it on people. You just go measure it, and then you compare it to a PA catheter. And you measure the stroke volume on the PA catheter, because that was the gold standard for years. Now, especially in internal medicine and critical care, we're largely getting away from PA catheters. That does not mean they're not useful. I actually think they're very useful. I think it's a question of a question you're asking it. But one problem we do have in critical care in general is because we're using fewer. So when I was a resident in the late 90s, we would probably put in 3 to 5 of these a week on my service in the ICU. Easily. Easily. And now, I don't know, I probably do, what, 1 every month to 2 months, you know, not that often. The reason it's important is because they would compare pulse pressure variation, stroke volume variation against the PA catheter. And what they would do is they would say, okay, I'm going to measure the cardiac output on the PA catheter, and I'm going to measure the pulse pressure variation. And then I'm going to give fluid, and I'm going to see, did the cardiac output improve? And a positive response was defined in most studies as an improvement in your cardiac output of 10 to 15% with a liter fluid, a liter Challenger fluid. So if you thought the person had pulse pressure variation, and you gave them a liter fluid, the cardiac output should improve by at least 10 to 15%. It may be transient, but it should improve. So what did they find? They found a pulse pressure variation of greater than 13%. So if the difference between your systolic and diastolic changed by more than 13%, then the person was probably dry. If it changed by less than 13%, that SVC stayed plump, that IVC stayed plump, you were up here, less than 13%, you didn't respond to fluid. Okay? So how do we measure these things? There's 2 ways. The cheap way and the expensive way. I like the cheap way, but I use the expensive one as well. Okay? Here's the cheap way. Look at the A-line. There's a pulse pressure on the A-line, right? Systolic, diastolic is right there. So what you can do, and you guys have all seen me do this, you walk up, you change the speed, okay, the sweep speed on the A-line, so it crams a bunch of heart rates right together, okay? Then you optimize the scale as best you can, make it nice and big, and then you watch it vary. And if it varies a lot, if it varies by more than 13%, they're dry. They need volume. They need more volume. I shouldn't say dry, they're volume responsive. They need more volume. If it changes by less than 13%, they don't need more volume. Now, if you want to be a purist, you should print out that strip, measure the narrowest pulse pressure, measure the biggest pulse pressure, and see if there's a 13% difference between those two. That's about 13% is how I do it. Okay? There's a lot of variability. Okay? There's probably nothing magical about 11 to 13%. Okay? If it's at 14 and I gave volume, yay. Yay me. If it was at 10 and I thought it was at 13% and I gave volume, okay. Patient's probably going to do just fine. Because the next time I check, it'll definitely be over, it'll definitely be under 13 by then. So that's the cheap way to do it. Then there's the expensive way to do it. Okay? Stroke volume variation. If I'm going to physically look at stroke volume variation, then I have to be looking at the stroke volume. The only way I can do that, technically, is to collect it in a cup, but we're not going to do that. I could use a PA catheter to do it. Okay? Could use a PA catheter to do it. And if there's the late 90s, that's exactly how I would do it. I would look at the PA catheter, see if there's variability in the stroke volume readings, and then if there were, I'd give volume. Okay? But let's say you don't have a PA catheter. Let's say you wanted to spend even more money. Do we have anything up here that we've spent more money on that we can use? Nikon, and what else have we got? Yes, absolutely. So let's talk about both of those. Let's start with the Vigileo. How does the Vigileo, the flow track, how does the flow track decide what your stroke volume variation is?
Complicated calculations.
Yes, there are complicated calculations in it. That's exactly right. In a nutshell, though, let's make it uncomplicated because I went to a state school in the South and I was a biology major. So we're going to stay far away from math. We're going to stay far away from reading. We'll make it simple, okay? We're just going to draw pictures. So, arterial blood pressure goes up. There's a notch, comes down, right? Up, dichrotic notch comes down. That's typical A-line tracing, okay? As best as I'm going to be able to draw it. So, what they've done, and let's say that's the biggest one I get, and then the smallest one I get looks something like this. Right? There's clearly a difference between these two. You can see it. Okay? You walk into the room and you can see it on the A-line tracing, but if that wasn't enough money for you, you hooked up the flow track. Okay? So how does it decide what a stroke volume is? It doesn't. It makes up a number. Totally makes it up. Totally makes it up. But it makes it up in a rational way. Thus said complicated calculation. But what it's really doing is it's paying attention to a point just past the dichrotic notch, and it's measuring a surface area. Okay? It's measuring the volume under this curve, and then it does it for here too. This volume is proportional to a stroke volume. And it doesn't matter what the actual number is that the flow track comes up with, whether that's actually an accurate number. It only needs to be directly related to the actual stroke volume. So whatever percentage difference this is from the actual stroke volume, as long as this percentage is equally different, it doesn't matter. Okay? And because you're building each off the same calculation, the percentage error is going to be the same. So basically all it's doing is comparing area here and area here. And guess what? If this and this vary by more than 13%, you're volume responsive. Check. Okay? So we've got two ways to do it so far. We can do a pulse pressure variation, look in the A-line. Actually 3 ways, right? Because we could actually look at a CVP tracing, and there's a lot of variation or there isn't. Problem is the numbers aren't quite as hard and fast for the CVP tracing, but you could do it that way. Or you could do it this way. So flow track, you have to have an A-line to do it that way. You have to have an A-line. A-line can't be kinked. Shouldn't have an A-line that's 6 days old, right? Really ought to be a new A-line. Can't be kinked. Can't have positional problems, right? Last but not least, you can use the Nikon. So let's talk about that Nikon. That thing is crazy fun. So, one of my colleagues in ER, ER critical care, great guy, Jordan Bonmo, fantastic guy. If you haven't worked with him, highly recommend working with him. He's fantastic. He loves technology more than anybody I know. And he really wanted this NICOM. And he lobbied, and finally got it. We got, I think, one for each hospital, each unit. We definitely got one. Two, I think, maybe. But I like it. I think it's fine. Here's the thing. Here's how it works. So this is your patient. And because, like all patients in the medical ICU, he's young, thin, and fit. He has X's for eyes. That's how you know he's sick. And here's the thing. There's 4 pads on here. Okay? 1, 2, 3, 4. Somewhere in here is a heart and an aorta. Okay? So, these 2 pads are related to each other. You go back to the NICOM. These 2 pads are related to each other. And go back to NICOM. Okay? In between, just make sure we got it. In between this pad and this pad, it sends an electrical current from here to here. Sends it out here, measures it here. And what determines how this electricity flows is how much water is in the chest from here to here. Okay? Because electricity doesn't flow through a brick, but it'll flow through water okay. Alright? So you can calculate 2 things. You can calculate the apparent resistance, and you can calculate the apparent capacitance between these 2. Okay? Do the same thing on this side. Now here's what's cool. Here's what's cool. The machine draws 2 graphs. One for this side and one for this side. On this axis is resistance. This axis is compliance. This is awesome. You ready for this? Let's say you could freeze this person. Freeze all the fluid in the chest. And then you measure this here, and you get a certain resistance and a certain capacitance. Maybe I get a resistance that goes out to here, and a capacitance that goes up to here, so I get this vector right there. I do the same thing on this side. Resistance goes out to here, capacitance goes up to here, I get a vector that's right there. Bam! Now, the heart squeezes. What changes in the chest when the heart squeezes? Water, volume, goes from here out. So then I freeze it again. Freeze it again. Bam! Right as this comes out. I have a different resistance across here, a different capacitance across here, a different resistance across here, a different capacitance across here, which means I now get a vector that goes from here to here. And then over here, maybe I get one that goes from here out to here. This difference in the angle and the difference in the resistance and the compliance correlates directly with the volume that moved. The only volume that moved in your chest during that time is the blood volume that came out of the left ventricle. Now, you might say, well, what about the volume that came out of the right ventricle? It's the same. Right? The exact same volume that comes out of your left ventricle is going to be the exact same that comes out of your right ventricle. There's only a certain amount of volume that's changing positions during that time period. That volume correlates directly with the stroke volume. It is brilliant. You don't need an A-line. Okay? It gives you the stroke volume variation. Sweet. Interesting thing. I can think of at least 4 patients that I've had up here in the last year that I've had a NICOM on and I've had the Vigil AO on. Do you think they agree in terms of the cardiac index and cardiac output they produce? I've had cardiac indices that are off by 1, 2, stroke volumes that are off. I don't know. So the question is, which is better? I'm not 100% sure. And it may depend on your patient. It may depend on a bunch of variable things. Don't know which is better. I use them both. Sometimes it depends on what's available. I don't know yet. What I do know is this. Stroke volume variation and pulse pressure variation were validated in very specific settings. Patients had to be in sinus rhythm in the studies. When they were on the vent, they had to have 8 to 10 cc's per kg for a tidal volume. They could not be taking spontaneous breaths, because if you suck in hard and you take spontaneous breath, you affect how much volume is going back to your heart, right? Sinus rhythm, 8 to 10 cc's per kg, not taking spontaneous breaths, which is exactly never in the medical ICU. Has never happened in recorded history in human medicine. So, we are still left back at the same place, which is, how do we assess volume responsiveness in the ICU? It is the holy grail of critical care medicine. I kid you not, it is the holy grail. At the end of the day, the most effective way to do it is to give them volume, measure the outcome, and see if you got what you wanted. Swear to God, it's the best you can do. But you can go and use pulse pressure variation, you can use stroke volume variation, you can look at the CVP tracing, you can do passive leg raise. The only sin is to look at the CVP number and trust it, unless you know the person's in heart failure. Then it's helpful. But outside of that, you don't know. And it is hard. But conceptually, you have to understand what you're looking for. And what you're looking for is not a static value. There isn't a particular pressure that you need to give, that you need to get to. Okay? What you're looking for is, when do things stop improving if I give more volume? When have I given enough? And once I've given enough, then I start working other pieces of the equation. But when have I given enough? And it is still one of the hardest things in all of critical care that I can think of. I struggle with it every day on the majority of my patients. Really, really struggle with it. And sometimes you just look to see if they're getting better. But the important point is, whichever path you go down, you have to have an endpoint that you're following. So if I'm doing a passive leg raise, then hook them up to a NICOM, hook them up to a Vigileo, put them on a PA catheter, do something to assess the cardiac index. Know that it's getting better or worse. If you're just going to give volume, look at their cardiac index. Whether you do it non-invasively or invasively, figure it out. Maybe you're on the wards and you're just going to clinically do this. The urine output picks up, lactate comes down, blood pressure gets better. These are all things that you can follow. But the point is, you have to have some endpoint. I'm not just going to give volume to give volume. I'm not going to just give volume to get a CVP of 12. It means nothing. I'm going to give volume because I want to improve my oxygen delivery. Specifically, I want to improve the cardiac output piece. So if I want to improve the cardiac output piece, I have to measure the cardiac output. If I don't have the ability to measure the cardiac output, then I have to have some way to measure the oxygen delivery. So maybe I clear my lactate. Okay? But you have to have some endpoint. You got to know, I gave it, things did or didn't get better. Okay? It is a challenge. It is hard. So with that though, that is the basics. Those are really the basics. And again, you don't have to memorize any of these concepts. Don't make medicine harder than it needs to be. Medicine at its base is a fundamentally easy thing to do. It's an endurance test, but conceptually it's not hard. In terms of things you got to know to keep somebody alive, it's basic physiology. If you want to know if a person's going to get better with volume, see what they do with volume. The nice thing is, with pulse pressure variation, stroke volume variation, CVP tracing, you're watching what happens with more and less volume. You're watching it. You can see it on the screen. If there's a lot of variability, it seems to get better when there's more volume, and it seems to get worse when there's less. It seems to get better with more volume, seems to get worse with less. Maybe I should give more volume. It stays the same no matter what. Maybe I don't need more volume. Now, somebody out there has thought this question but didn't ask it. Somebody very smart has thought this question. I'm looking at you, Carolyn. I'm looking at you.
I thought you were going to say somebody young.
Somebody young and smart like Carolyn was thinking this. What if you're way down here on the curve? Like you're really, really dry. Right? I mean, if you're really, really dry, it actually kind of plateaus back out again. If you're that dry, then there may not be much of a change in your stroke volume with volume. To which I would answer, yes, but you're dead. If you're that far down on the curve, it's all a moot point. So the question is whether you're on a straight part of the curve where each increase in preload correlates with an increase in stroke volume, or are you at a part of the curve where each increase in preload has no change in the stroke volume? That's what you want to know. All this stuff is driving towards answering that question. And at the end of the day, you live on an island where you don't have an ICOM. You don't have a way to check pulse pressure variation. You can't do any of this stuff. I was going to make an Ohio State joke, but I won't. Let's say you're on an island where none of these things are possible. Give volume. The only patient you can't give volume to as part of your little experiment is the person who you know is crazy volume overloaded. Who is that? The profound heart failure dude. Whether it's right heart failure because of PE, or biventricular heart failure because they're bad coronary artery disease, what do they have? JVD. If you see JVD on the exam, they're at 45 degrees and you actually see JVD, you can't give volume to them. I don't know what's going on in them yet, but volume is not the answer, and you will make life worse for them. That's the only patient. Everybody else, if you're not sure, give volume and see if you get a response. That's it. So anyway, so that is assessing volume responsiveness, figuring out what to give. Whole talk for a different day. That's a whole other 45 minutes in and of itself, at least. But I think that's about it. So, questions? You guys see one?
Nothing right now.
Well,
Yeah.
this is very important. So when I'm in rounds, and I know I speak for the other attendings, but certainly when I'm on rounds, talk about it. Because I guarantee you, we are flipping it around and we're not sure either. Talk about it, bring it up, jump into the discussion, okay? You're gonna have a perspective standing next to that patient 12 hours a day that I'm not gonna have. You will probably be more accurate in your clinical assessment of this person's volume status than I will be. I guarantee you will be, okay? Bring it up, okay? Because I need that, absolutely need that. Because, and I always tell my residents this, and this is absolutely true, you will kill more patients during the course of your career with inappropriate volume than any other thing do or don't you do. And inappropriate volume management. Some patients who were dry and you should have given volume to, you were late. Some patients who were too tanked up and you kept giving them volume, didn't get it off fast enough, bad. Both of those are bad. You want to be somewhere in the middle. You don't want to be on either extreme. Statistically speaking, you will harm patients over the years with volume, not because you're stupid, but because it is hard, okay? But the low-hanging fruit, take the technology you got, take the concepts you got, and try and narrow these problems down as much as possible so we're not harming people, okay? As best we can. It's an imperfect science, but at least conceptually, just keep track of the idea that what I'm trying to assess is volume responsiveness. Not dry, not wet. Volume responsiveness. Is my oxygen delivery going to get better with more volume or not? Anyway, thank you.